got a big topic.
Oh, yes.
We're good?
Yep.
Okay, thank you. We're going to get started. Sorry for the little delay there. Some technical roadblocks, but we're good. So I am Steve Little. I'm a co-presenter today, Dr. Rifai. We're going to go through some echo and then other secondary, much less important modalities in relation to endocarditis. So this is an update on an annual lecture. Hopefully you'll appreciate some of the updates, although endocarditis hasn't changed an enormous amount over the decades, but there are some new things to think about. So I'll just give you a reference. ACSAP, you've all got access to. Dr. Chamsi Pasha and I and one of our former surgeons, Dr. Ramlawi, wrote this chapter. Some of the questions we've updated a couple of times, so if some of this looks familiar to you, or if you want to see it again, just go to the ACSAP chapter. A lot of the similar messaging is in there. Okay, so first question, this is often the echo conversation, is what is a vegetation? So here's the single example to try to highlight this for you. So what does something have to be to call it a vegetation? It has to be a mass, okay. It has to be somewhere where you don't expect a mass, typically. And one of the hallmarks is the description of the motion, which is called oscillation. So in the audience here, we've got lots of fellows. What does the word oscillating mean? And the hint is it means more than moving, but specifically, what is oscillating? It varies with motion, yes, but not so much the shape.
Independently mobile?
That's the key, yes, exactly. So it doesn't move in synchrony to the heartbeat, right? So a lot of like a tumor plot, for example, it moves once in diastole, once in systole. It's rhythmic and it basically mirrors the heartbeat. Oscillating masses do not. So I'm giving you the very specific rules of endocarditis, and then for the rest of the talk, we'll explain how we break the rules. But it's understand what the rules are. So oscillating mass is the key. So as you look at an echo, is it moving, yes or no? Is it moving independently of the cardiac motion? These aren't absolutes, they don't always work. Certainly a fast thrombus or a ruptured cord, there are other long linear things that can oscillate. But look at this thing. It's chunky, it's got linear parts, it's got a fat part, a skinny part, but all is sort of moving. Yes, it has a base rhythm related to the leaflet motion, but it keeps moving after the leaflet stops moving, and that's oscillation. Okay, here's a different one. This is a tricuspid valve with a small linear oscillating mass, just to give you two different extremes of what endocarditis masses look like. So another thing to think about is where is the mass? In general, endocarditis forms on the flow surface. Okay, that's because you need a rough kind of denuded surface. So healthy endothelium, super smooth, like satin. You can't get bacteria to grab on and stay there. And as soon as you disrupt it, whether it's through a congenital problem, a surgical issue, a foreign material, acquired a pathology, it's the rough material that allows vegetation to hold on. And the beat up surface tends to be the flow surface. So that's the atrial side of the mitral valve, or typically the ventricular side of the aortic valve. So think about where you see the mass, which side is it attached to? And that is another clue to what's probably endocarditis. Okay, this is straight from that ACSAP chapter. How do we get endocarditis and really what is a vegetation? So it's this cascade of stuff, right? You have damage, disruption to the endothelium, I mentioned that. You have inflammation that follows, you get fibrin deposited on that, then you get colonization, you get a little more fibrin, and it kind of grows and cycles. So you end up with these layers of fibrin, platelets mixed with bacterial and inflammatory tissues. That's what an endocarditis lesion looks like, a vegetation under a microscope. Okay, so I'm not going to go through all this. This is in every chapter, every textbook about endocarditis. The bugs, some are very aggressive, some are uncommon, some are common only and immunocompromised, some are common after surgery and they're considered nosocomial. I won't go through the list. You can all find the list. One thing to recognize how endocarditis has changed over the years is we have more older people. So endocarditis we're seeing more of. We have a lot more implanted devices, transcatheter heart valves, but also electronic devices, more pacers, more leads, more kinds of stuff sitting in the right side of the heart. So any foreign material meets those first criteria. It's a rough surface, so bacteria likes to land on rough surfaces. Okay, here's a more challenging one now. So we talked about the rules. Now we'll see if we break the rules. So what are the things that break the rule? So this is different. Obviously, there's a mass on the anteromitral leaflet, looks like a tomahawk. There's also some chunkiness on the posterior leaflet. Is this cancer? Is this thrombus? Is this a vegetation? That's usually the question we're asking most of the time. So votes in the room. Is it independently oscillating? No, not really. Okay. All right. What is this? It's on two different places. So it could be a cancer. Cancer doesn't usually do that. Go to two spots. So unlikely cancer, not oscillating. Could it be a thrombus? Thrombus likes to go in places that are low flow, right? The surface of the anterior leaflet is not low flow in a normal LV. So this is a head scratcher. It doesn't meet sort of the obvious things. So what breaks all the rules is fungus. So this is fungal endocarditis. Fungus does anything. Fungus can be massive, sessile, non-invasive. Fungus can be massively invasive. Fungus can oscillate. Fungus cannot oscillate. Fungus will go to places that nothing else goes. Fungus we don't see outside of immunocompromised, but we have a lot of transplant patients. So always remember, fungal endocarditis will break all the rules. Okay, Mark.
Can you tell that just from the image?
No, but you go through that differential. We said, okay, there's a mass. Is it likely thrombus? Unlikely, given where it is. Is it a cancer? Unlikely in two spots. So I'm saying even without oscillation, in that scenario, endocarditis has to stay high on your list. Usually that oscillating feature is helpful to differentiate, but that's the scenario where it's less helpful. I just show you that to confuse you. All right, so a more classic pacemaker lead, big chunks. Could be a thrombus, possibly. Could be a veggie. Clinical scenario helps. History of anticoagulation helps. And after a lead exchange, it's cleaned right up. So when it's that big, you'll often do a lead exchange because that's a mass that has risk of embolic phenomenon. This is one that's a little more subtle, okay? So we don't always see a beautiful pulmonic valve. Sometimes we do, but sometimes you see a space and you see the PA and you don't see the valve. You see a little flicker there. So you see something flickering in the region of a transthoracic view that shows the pulmonic artery and maybe to a lesser extent the valve. But when you put the color on, you've got this associated badness, so wide open PI. So this is the scenario where you think, okay, I think I might see something. Is it an artifact? Is it real? Okay, there's wide open PI. This thing is real. So that's how you go through. So a lot of things when you're looking for endocarditis and vegetations is there local destruction? It is uncommon to have a big mass on a valve and completely normal valve function. It can happen with non sort of invasive bacteria, but more often than not, this is the scenario. Okay, to get a little more complicated, non-infectious endocarditis. We don't see it often, but we'll never see it if we don't think about it. This is that scenario. So TE, mitral valve, you see the mitral leaflets there, and there's some sort of small little things. They're really small. You got to look for it, maybe zoom on it. They're hard to see by 3D, possible, but really this is the spatial and temporal resolution of 2D echo shows this well. And if hopefully you can see it projecting right near the coaptation zone. And if you look all around the valve in multiplane TE at 30, 60, 90, 120, you'll keep seeing these lesions. So it's not one lesion you go hunting for. There's a whole forest of them. And that tends to be that Libman Sachs. That's that endocarditis. And you look in the pathology, it's sort of all around the coaptation zone. It's usually associated flat, pale, tan if you open it up. And that's that non-infectious stuff. So, merantic endocarditis is the one associated with malignancies. And there we are. So we don't see a lot of that, but remember, if it's not behaving the way an infectious endocarditis is, there is an entity of non-infectious endocarditis. You could argue, is it really endocarditis? Well, it kind of is, because when you look at it, it meets the other criteria. You take the tissue samples, it's bland, there's inflammatory cells, there are platelets, there are fibrin, you just don't have the bacteria. So the vegetation can look quite similar, but it still meets the category of vegetation, but it doesn't have the size or the mobility. The other thing that's super helpful on echo, much like when you evaluate prosthetic valves, is the timeline. So this is very important. So when you're given the one-off image and you're told to diagnose it, that's a trick. So always look backwards, and then sometimes you have to look forward, which means not sure, but redo an image a little time later. So thrombus can appear, grow, and also shrink and disappear very fast. Nothing shows this better than we're in a cath lab case. Particularly, you introduce some catheters, and the tricuspid valve, we had this yesterday. Tricuspid valve is completely clear, nothing on it. End of a 1 hour case, there's a small wiggly around the tricuspid valve. It was not there an hour ago. That's a thrombus. Okay, so bacterial events don't appear within hours. Also, when you anticoagulate a known thrombus, it might be gone. If it's a fresh thrombus, it might be gone in a couple of hours of heparin. If it's a, something's been there a while, it might take days or even weeks to disappear. But the tempo of appearance and disappearance is very high of thrombus typically. Vegetation is kind of in the middle. They can appear, depends on the bacteria, over days and weeks. And if you look at serial echoes, days, weeks, or months apart, you might see a change in the vegetation. Typically weeks to months you will, not often within days. But that's got that overlap. Now recognize there's overlap there. They both have days. And the other one is tumors. Tumors don't ever shrink or disappear without an intervention. That's true. But the appearance is much slower, months, weeks, years. So when you have a study from 3 months ago, that's helpful. If you have a study from 2 weeks ago, that's usually helpful. If you have a study, the thing wasn't there 2 days ago, that's incredibly helpful. But sometimes you have something and you don't know what it is, it's not locally destructive, doesn't meet surgical criteria. It's okay to say, this could be a couple of different things, let's re-image in a month. So that's not uncommonly the approach. Talk a little about complications of endocarditis. Okay, so here's a TEE. Anybody see anything? Yep. What do you see? Posterior aneurysm, okay, so let's see here. Do you see this little bumpy thing moving around here? So is that what, I see heads nodding? Okay, there's a thing here. I would try to pause it, but okay, there's a little mobile mass right on the annulus, that's there. On the flow surface of the mitral valve, so it ticks that criteria, mobile ticks the criteria. Oscillating, hard to tell, it's small, maybe yes, maybe no. Anything else?
It looks like they're on the anterior leaflet.
Uh-huh.
There might be like a little, like right there.
Down here?
Yeah, right there.
So,
It's like something's opening up.
yeah, so this thing down here is actually just the insertion of the strut cord. So a little fold on there, but you're right, it often comes up in the discussion. This is hard to appreciate without the color, but what there is a little dropout, mid-posterior leaflet. So is that a perforation? Very easy to figure that out, you just put color on. So the local destruction aligned with a mass is endocarditis. Not a thrombus, not a tumor, if you get that. So that also helps you. And there's an arrow, if you weren't sure. Okay, and then when you take it apart, this is often what a leaflet looks like. They have this sort of volcano appearance, and it's often a heaped up. A windsock deformity is the phrase that's often used because you have local tissue weakness. You have hemodynamic effects that basically puff up the tissue like a balloon. So you get this long thing that looks like a sock. At the airport, what they do is they cut a hole in the sock so that it blows in the wind and tells the pilots the direction of the wind. So that's a windsock deformity. So basically it becomes a fistula de facto, but it often starts as this long linear sock-like projection with a hole in the tip. So this is a very sort of short windsock, but we've got examples in the lab of, windsocks of 2 centimeters, usually through the anterior or posterior leaflet. Okay. This is kind of one of the worst ones, just to remind you that endocarditis doesn't really have to be only in the heart, right? I mean, it's endothelial. It depends where you cry, but this is in the distal aorta. This is a dissection with morantic endocarditis, a veggie. This was a disastrous scenario, but endocarditis is really vessel endothelial dysfunction. Okay. Prosthetic valves, a word or two about prosthetic valves. In this era, we're challenged so many different kinds of valves, still broad categories of mechanical and bioprosthetic, but I've got all the transcatheter ones as well. Here's an example. If you can, there's a prosthetic valve in the aortic position. Do you see anything of concern? Anybody? I'll help you with an arrow. Okay, so remember, just a little bit distal to the prosthesis, there's a wiggling mass. What is this thing? So that would be the anterior part of the aorta, right? Because there's a T, so the back is at the top, the anterior is at the bottom. So when surgeons go in, they obviously open the chest, they do an aortotomy down the front of the aorta, open it, do surgery, close it, throw some sutures. So this is actually an infection at the site of a little suture nub that was left poking into the aorta. So it's about a centimeter distal to the actual valve, but that's where the endocarditis is in this scenario. So that's a post-operative, and that was actually a fungal infection. This is a different one. So bioprosthetic, another aortic valve. You see that thing? Does it meet the criteria on the flow surface? It's probably hard to tell what it's attached to, but it could be on the atrial surface or the LV surface. That's tough. Certainly long, and that's a nice example of oscillating. It's got lots of motion. It's independent of the cardiac structure. It's after an AVR. The point of me showing you that is that a different host of bugs enter the list with differential after you've opened the chest. So these are nosocomial things. Is there anything present in the OR at the time? And this is actually nocardia. So you don't generally see a nocardia infection outside of an open OR scenario. You're not going to see this at 1, 2, 3, 5 years. But this is the weeks to months, typically after open heart surgery. It's a long linear thing, and that's the re-op that shows up. Okay, just expanding the differential a little bit. 3D TE mitral valve. I think you can all see that long linear thing in the LA. Okay, based on our differentials and our discussion thus far, you don't have to be right, but what do you think this might be? Vegetation? Any guesses? Okay, thrombus?
Well, it's oscillating.
Uh-huh.
It's on the atrial side.
Yep.
But it's a weird shape.
Super long, so endocarditis, big categories. Tumor? Not tumor. Okay. Thrombus? No thrombus. Leaves us one. Endocarditis? Okay, except for the fourth category, which I didn't tell you about yet, is foreign material. Retained foreign things, and that's what this is. This is the attuned surgical ring, and it's a ring that the surgeon is supposed to tie up in a knot and snip the knot, except they didn't know to snip the knot. So they sewed the ring in, never actually did the belt tightening and snipped it, and they left the threads flying. This was done at another hospital. This is the classic outside hospital sends patient for endocarditis. Open the op note and you find out the surgeon actually never tied those little strings on the ring. So that patient still has this ring and these things flying around, now with anticoagulation. So the point of is...
Really? You guys didn't take it out?
No, there was no MR. I mean, these are sterile surgical rings that should have been snipped, but they're just floating around in the LA. You know, if you look at the randomized trial of 1,000 people like this, no, but this, what do you do here? You're not going to reopen somebody to remove something that isn't causing a problem at the moment.
There's no risk of that flying off?
No, it's totally contained within the, see, this is the ring, and this suture is contained within the sewing ring, and it's a mechanism of the surgeon sews on the ring and then supposed to pull this cord like a belt, make a knot, and throw a little knot tower.
Okay, so that's not the actual ring, that's the cord.
This is the cord, yeah. What you're seeing on the image is this blue cord. You see the ring as well. The ring is down here, and this is the cord hanging off the ring. So just to point you, there are occasionally, not very uncommonly in the left heart, but sometimes right heart, you'll see a wire, you'll see a guide wire that slipped in, and believe it or not, somebody forgot. We find guide wires in the RA bouncing around. So these foreign material is the other thing to think about. It's usually pretty obvious. Okay, prosthetic valve endocarditis with the mechanical valve. So the message here is veggies, I would say almost never, I've never seen it, attach to the metallic leaflets, right? They're super smooth, super soft. They're thrombotic, but they're not really easy for veggies to attach to, the pyrolytic carbon leaflets. So this is a nice example of where the veggies attach is on the sewing ring, and it's prolapsing in and out of the valve. But I've never seen a case of a veggie, defined, confirmed veggie, on the metallic leaflet. Bioprosthetic valve, absolutely. They usually go on the leaflet, but on the metallic leaflets, no. This is the bioprosthetic valve. That's kind of a pretty typical endocarditis, big chunkers all over the valve. This was a patient who had, so this is an absolute indication for surgery. Culture positive, this echo, you're done. That's definitive endocarditis. Take, redo, if possible. This was somebody with high surgical risk. Yeah, well, that option just disappears. What do you do with this? You treat with appropriate antibiotics. 6 weeks later, ta-da, that mass is gone. So an incredible Hail Mary medical therapy of bioprosthetic mitral endocarditis, except it's not quite that simple. So the big mass is gone, but the veggies didn't leave without a little local destruction. So if you look at the color, now we have 3 little punctate lesions of PVL. So there is a paravalvular sequelae of the infection that wasn't there before. And then also if you look at the leaflets, it was probably more evident on the 2D, there's actually some chunking and scarring. So the effective orifice area is actually smaller. So there's a little bit of residual stenosis now, even after the resolution of the leaflet vegetation. So the leaflets don't really emerge scot-free. They're damaged. This patient didn't have another choice. Mechanical mitral, looking at the leaflets, looking at the sow ring, a little bit of sort of a blood mud smudge on the right side of that image. Not sure, anybody idea why that sort of brown stuff is here? Any of our echo imaging fellows? This stuff? Pardon me? Well, you could get rid of it with gain, you're right. So you can always gain down the blood smudge. The issue here is that, yeah, right, Russia. All of this is a massive dehiscence. So remember, it's not always in the valve, it's the tissue around the valve. So this is a quarter of the circumference of this valve dehisced. And this blood mud stuff is actually the paravalvular MR. Because there's a hose of, I didn't show the color, but there's a ton of color coming right through that. So this was a very sad case of a physician who had like a 3rd time redo, whole valve, whole crux rebuilt, didn't have another surgical option. But at first this was looked at and said, oh, good news, no veggie, except we have massive destruction of the tissue around the heart. So all that to say, remember the crux, the fibrous tissue that holds the heart together, aortic mitral and tricuspid valves are all interconnected. Pulmonic valve hangs out by itself very anteriorly, so it's not actually connected by fibrous tissues, but the other 3 are. And bugs can invade in any direction, and I'll come back to that in a second. So I like this case. So this is a 75-year-old who had a bioprosthetic valve 2 years ago, comes in with fevers and chills. Typical long axis TE view. Anything of concern? Silence. I was silent too. Keep looking. Drop an X-plane, always helpful. And you can see when you go just a little bit above the valve on the left image, there's a chunker kind of bouncing in and out of the valve. Okay, a little chunker there. As always, we do some Doppler. And this is actually an impressive stenosis. So we've got this velocity, at least on this beat, is just over 4 meters, just under 4 meters. So rarely does endocarditis by itself cause functional stenosis. You'd have to be a massive. But in a bioprosthetic valve, you've already got a compromised flow area, it can. So this is a scenario where the fevers, the chills, and the stenosis helped, and then finally the X-plane TE helped lead to the diagnosis of prosthetic valve endocarditis. So again, we have a bioprosthetic valve, okay, supposed to go to surgery. And one of the messages, when the patient can go to surgery, just go to surgery. Just go to surgery, please. Often it's the surgeons don't want to. Okay, but kick the can in a month or two. Kick the can a month or two. Great news. After 2 months of antibiotics, the mass is gone. So we have effectively treated the stenosis. Celebrate. Do we celebrate? Isa, do we celebrate? Why don't we celebrate, Isa? Yes, right here. Look at, even despite antibiotics for 2 months, now we have this stuff. So what is all this? Yeah, that's an abscess. So this evolving periprosthetic abscess, despite 2 months of parenteral antibiotics. And this is what you expect of a bioprosthetic surgical valve, because you can't get the antibiotics to that spot. They're not going to penetrate ever. All right, and then if we look, so send for redo. But when we looked back at the very first echo 2 months ago, we were all enamored by the mass and the stenosis, but it was already there. It was starting. And I think if we'd made the call then, you would have said to a surgeon, there's no point in waiting 2 months for this. You know what's going to happen. So this is important to recognize these little events. So the anatomy, it's also close. Left fibrous trigone, right fibrous trigone. AV node is here. All of this tissue is interconnected, particularly an aggressive bug like Staph aureus will connect any plane. So remember, when you're considering endocarditis, you've got to interrogate. Just another echo view to show you. Aortic valve is here, this intervalvular fibrosa in the interconnection of all these tissues. And that aggressive bacteria don't respect any of your tissue planes. They'll go wherever they want without necessarily rhyme or reason. And this is an important series of slides to talk about nomenclature and sort of a natural history of what happens. So again, an aortic root abscess. You can see it here, okay? So it's, in this case, it's fairly homogeneous in its color, but it isn't always. This is one that is less homogeneous. And that's pretty typical. So a focal inflammation, no history of surgery recently. It's a native valve. That's an abscess. But notice it's not pulsatile. That's the key to an abscess. An abscess, by definition, is still contained. So once it ruptures, it's no longer an abscess. When it ruptures, you often have a massive kind of SIRS effect and a white count and a fever and all the things because your body suddenly gets a bolus of bacteria. But while it's ruptured, or while it's contained rather, it's not pulsatile. So natural history, now you perf in the LVOT, now it's pulsatile. So all the pus has been released. You feel bad in that moment for sure. But now you have this. So pulsatility usually means it's open on one end. And you can add some color. You see the color in, flow out. You've defined that it's pulsatile. So that is a pseudoaneurysm by definition, open on one side, with a contained space that shouldn't be there. Let's say you open the distal end now. Now you open it up into the aortic root, same bug, or same lesion. Now you have a fistula. So a fistula by definition is a channel where there shouldn't be a channel, open on both ends. So as we learn and use these terms, abscess, pseudoaneurysm, and fistula are not synonymous. They really refer to different stages. This is an example of an aortic to RA fistula. We know this as a Gerbodi defect. The vast majority of Gerbodi defects that we will see are post-intervention, typically a surgical AVR, and that's a hole really through the membranous septum, the connection to the RA. So we've seen a number of these in the echo lab, Gerbodi defects. And then finally, TAVR, again, is a little weird. It's got its own little collection of things. It's a fairly recent case. Big bacteria on a transcatheter aortic valve, a funny connection here even into the RA, and there was a lot of funny flow. Good quality TE. We see stenosis of the TAVR with a flow convergence, and we have flow kind of rupture. And this is very likely the distal end of the frame causing compression combined with infection. It opened up a channel right to the RA. Okay, so in summary, endocarditis is inflammation of the endocardium. Very simply, it usually involves the valves, but it can involve a lot of other structures, septa, chordae, intracardiac devices. The lesion is a vegetation, platelets, fibrin, and typically bugs. And then echo is the mainstay of diagnosis and treatment. This is an old sort of workhorse to sort of how we approach this, indicating that if you're definite already, you're basically done. If you have prosthetic valves, you very often get into the fancy imaging we're going to hear about now, and a pretty low likelihood for TE. I would say a very low threshold for consideration of endocarditis on any prosthetic valve, because there's a lot of hidden things and shadows that the TE will help you with. Okay, sir, you're up for the complicated stuff.
All right, thank you, Dr. Liller. I will now be discussing the cooler imaging modalities to diagnose endocarditis. I am not Dr. Al-Mallah. Mahmoud Rifai, one of the new imaging faculty, and I'm presenting on CTA and PET for endocarditis on behalf of Dr. Al-Mallah. All right. So as you all saw, echo is the first imaging modality to diagnose endocarditis. We'll never get a referral for CT or PET without having an echo first. So echo is always first, but it's not always last. Okay, we do get these CTs at baseline and follow up to see regression, progression. So it's not always last. So what's the role of CTA in endocarditis? It's not really to diagnose per se, but it's really to look at complications. Now you can see on this image that there's a thickening of the aortic valve, right? There's a focal thickening that's independently mobile. I would bet you that you can see this image on echo, right? Whether it's TEE or TTE. So the role of CT is not really to diagnose it per se, but look for complications. Is there an associated pseudoaneurysm? Is there a fistula, which is by anatomic definition, not really physiologic? So that's really what why we order CT and PET. This clear, you can see here, there's some pseudoaneurysm at the root. So that's something that we can more obviously see with CT sometimes and not just echo. Obviously, those patients, when we get them to the scanner, we want to look for valve motion and dynamic mobility, so we do these retrospective. So the patient's irradiated, and they do get a relatively higher dose of radiation. The temporal resolution of CT that we have over here at Houston Methodist is about 63 milliseconds. So very fast mobile vegetations might be missed, but bigger, slower vegetation will definitely be seen. So just know that if a vegetation is very fast, it might be missed on CT. And then lastly, with CT, we do get the entire field of view, right? We're scanning arch to apex sometimes, and we do involve some superior portions of the abdomen, so you can look for complications associated like infarct. Here's another example of a large vegetation that you're seeing on the ventricular side of the aortic leaflet. So what's the difference between CT and TEE? I think Dr. Little alluded to a lot of the utility of echo in diagnosing endocarditis. So vegetations usually, especially on TEE, can be seen somewhat better than CT because of the better spatial resolution. Again, the temporal resolution of echo is much better, especially when you're using Doppler and looking for flow. But just know that these small, highly mobile lesions might be missed on CT. Complications of valves, of endocarditis, like abscess, pseudoaneurysm, sometimes might be easier to visualize with CT. I think we saw that image of a early abscess that might have been missed on the initial TTE when it was not as obvious, but CT might be a little bit better in visualizing. I think prosthetic valve endocarditis, there's definitely a role and an advantage for TEE. Looking for dehiscence, regurgitation, fistulas, definitely TEE and TTE, where you're actually assessing flow. It can only be done with echo. Pannus, thrombus, and calcification of prosthetic valves, I think, are better seen and assessed with CT as compared to TEE. And then whenever you have a perioperative redo surgery evaluation, typically a CT is helpful in those situations. And then extracardiac findings, obviously by definition, the echo is only looking at the heart, whereas with CT we get a better field of view, so we can look for extracardiac findings. And we have some illustrations in the next slides. So what are some local complications that can happen? You see this valve, looks like there's dehiscence and there's a pseudoaneurysm that's forming there. And then you can see it here on this view as well. This patient might, I don't know if it's not a video. You can see that there's a fistula, there's a fistulous communication, or at least we can say there's a communication between the aorta and the LA. But again, flow and stuff would not be really visualized. You can see contrast moving in between the two chambers, but definitely if you're looking at hemodynamic assessment, that's much better accomplished with echo. And then lastly, this is a pseudoaneurysm of a bioprosthetic aortic valve. You can see here at the right cusp, or you can see the pseudoaneurysm formation. And again, all these patients have had echo before. So we know that there's something wrong, and then they get referred to us. It's not the first step that we're doing with CT. Thrombus, pannus, as you know, are complications that can happen with prosthetic valves. And really the best way that we can distinguish between the two is with Hounsfield units. Thrombus typically is, most of the literature suggests that anything less than 90 is probably thrombus. You can see here at the root, particularly at the left coronary cusp, and here at the non-coronary cusp, there's some thrombus formation. And then pannus, on the other hand, because it's more fibrin tissue and degeneration, it's usually of a higher Hounsfield unit. But just know that there's overlap between the two and might not be really easy to distinguish, but this is usually the cutoffs that we use for 90 and 145. And again, here is another example of a TAVR valve where you can see thrombus here, and then you can see this is the calcification of the LVOT and the native valve here. So what are Hounsfield units? I think most of fellows who pass through the CT lab are well familiar with Hounsfield units. The index that we use is water. That's your reference. And that has a Hounsfield unit of 0. Fat has a negative Hounsfield unit. minus 50 to minus 100. And then air and lungs is very negative. And then soft tissue has more positive Hounsfield units. Thrombus, which is close to blood, is somewhere here. And then bone and metals have very high Hounsfield units. So whenever you're seeing this possible complications, we always draw an ROI there and measure the Hounsfield units, because that is what allows us to distinguish between thrombus versus pannus. Now, bioprosthetic valves, again, easily seen with CT. This is an example of a retrospective study. I don't think it's projecting very well, but you can see here at one of the cusps, it's probably the left, there's some thrombus formation here. Abscess versus no abscess, again, these are patients that are referred after having had an initial echo. And so whenever the Doppler is suggestive of an abscess, just looking at that complication anatomically is best accomplished with CT. You can see that there's some color here, and then I don't know if you can appreciate this thickening anterior to the right coronary cusp. If you look at the normal CT, that thickening is just not there. This is an abscess, early abscess formation. And then, as Dr. Little very nicely illustrated, abscess versus pseudoaneurysm versus fistula, it's not really synonymous. There are different stages, but really that physiologic definition is only accomplished with echo. Now, the role for CT versus TEE is really helpful when you're not sure about the diagnosis. You can see these are patients who underwent both CT and TEE for within 3 days of one another. So those patients underwent both CT and CTA. So we'd like to think that there's no referral bias in this case because they underwent both tests. But clearly, the fact that they underwent both tests tells you that they're at a higher risk status compared to someone who only underwent one. And in those who are TEE negative, so you didn't see anything on TEE as far as vegetations are concerned, none of them had any evidence of vegetations on CT, which shows you that TEE is really very good to diagnose just the presence of a vegetation, yes or no. But what the advantage of CT is in diagnosing these complications. So perforation, aneurysm, abscess, pseudoaneurysm, fistula, dehiscence, these are better seen on CT when the TE is negative. So if the TE is negative and you're still unsure if there's some anatomical complication, then CT would be the next best step to better visualize them. And you can see that patients who've had infective endocarditis after a transcatheter aortic valve replacement, those patients will have a much lower survival, especially if that infection is left unchecked and undiagnosed. So if you're suspecting it, get an echo, get a CT, because if it's left untreated, this is the natural history. They're just going to die. That's very important to diagnose early on. Now, extra cardiac involvement is another nice feature of CT, because that field of view also involves the upper abdomen. You can see the spleen. Does anyone notice anything with the spleen in this case? Here's the spleen, by the way. Huh? Yeah, there's like this wedge-shaped infarct. So this is very concerning, especially in a patient with possible endocarditis here. You can see on this cusp. This is very concerning for distal embolic embolization. Other complications, brain abscess. Obviously, I'm not a neurologist and we don't really cover the head, but just know that you can see these on CT. Again, you can see these splenic involvement with distal embolization. Kidney also, if you see, if you do a CT abdomen pelvis, you can see these wedge-shaped infarcts as well in the kidneys. And then this is the abdominal aorta, and this is a mycotic aneurysm. CT has a very clear advantage in perioperative risk assessment, so we can look at the coronaries as well. We're scanning these patients retrospective. So we have all the phases of the cardiac cycle, so if there's motion in the RCA and systole, we can look at it in diastole, and that way we have a very good visualization of the coronary arteries. Obviously, patients who undergo coronary assessment have to have beta blockers and nitro on board. But sometimes the heart rate is really high. Because we have a very high temporal resolution of our scanners, we've scanned patients with heart rates of 120s, 130s. But then if you have someone with wide open AI, for example, when you have very low forward flow, the only way they can compensate their cardiac output is with increasing the heart rate. It becomes very difficult to control those patients' heart rate. So we just have to bite the bullet and scan them. But luckily, we have a very fast temporal resolution that we're still able to look at the coronaries. So perioperative assessment, really the sensitivity of CT for perioperative assessment to rule out obstructive CAD is 0.93. So that means that if you have a normal CTA, you can pretty much be certain that there's no obstructive CAD and clear that patient for surgery, and also has very high specificity. So perioperative risk assessment is another very important role of CTA. So CTA, I won't dwell too much on this, but just understanding that the complications of infective endocarditis are very helpful to diagnose with CT. Okay, and I think we've talked about this point on some of the other slides. Now switching gears to PET. PET is a very useful modality to, again, help diagnose infective endocarditis. This is an example of a 78-year-old patient with a prosthetic valve that was implanted 3 years ago. And they, on criteria, they do have definitive infective endocarditis. And this is the bug, Streptococcus. This is what you're seeing, the light bulb here, this is FDG. Okay, FDG lights up when there's infection, there's inflammation, infection, well, specifically I should say inflammation. Diagnosing infection versus inflammation on FDG PET is hard, just because if you have FDG uptake doesn't necessarily equate to infection, but in the right clinical context, that translates to infection. Other thing here, if you can appreciate that this ring around the root is not really homogeneous, right? It's not homogeneously bright throughout. You can see that there's more intense FDG uptake here versus here and there. This is one of the other hallmarks of infection, that this heterogeneity in FDG uptake. So that's another way to help distinguish infection versus inflammation on PET. So what's the protocol that we use to, for these patients who undergo PET for FDG? So if you're looking at anything in the heart, so native valve endocarditis or prosthetic valve endocarditis of the mitral or aortic, know that the aortic and mitral valve, as you know from anatomy, are very close to the myocardium. So you want to make sure that you make that blood pool as you want to try to eliminate the blood pool from your FDG. So what we do is we do a myocardial suppression diet with low carbohydrate and high fat. So low carbohydrate diet at least for 12 hours, and then they fast for at least 12 hours before the test. On the day of the test, we give them heparin if it's not clinically contraindicated. We give heparin just for additional myocardial suppression. And then we inject them with FDG, and 60 minutes afterwards, we image for about 10 to 15 minutes. And I want you to appreciate the difference in a patient that underwent cardiac preparation versus none. This is the LV, and you can see it's all just a bunch of blob, right? It's all dark. You can't really appreciate anything. Versus a patient who underwent adequate myocardial suppression, you can see that now you can clearly visualize the FDG uptake in the aortic valve. So patients, when you're suspecting either valve endocarditis, mitral, aortic, pacemaker lead, LVAD, anything that's within the heart, make sure that we're telling the physician that so that they can get adequate myocardial suppression. If I'm just looking at a graft, for example, in the ascending aorta, descending aorta, we really don't need to do cardiac preparation in that case. So PET and CT fusion. So again, PET and CT is synonymous, right? When we're doing PET acquisition, there's always CT co-register. Now, sometimes those patients also have had a CTA with contrast. The CT that we use for co-registering with PET is without contrast. But some of those patients have had CT with contrast in the past few days, and fusing the two images together is very helpful for better localization. But this is a patient who just underwent a regular PET CT, and you can see clearly here that the area of FDG uptake is around the valve, right? You can see that it's ring that's heterogeneous because it's not uniformly intense. So this is looks like an abscess here, some thickening around the root. This is a mechanical bileaflet valve with, again, heterogeneous FDG uptake. This is an example of a I think this is a bioprosthetic valve, again with very heterogeneous focal FTG uptake over here. And again, the difference between infection and inflammation is that infection typically is homogeneous, heterogeneous, and intense. Inflammation is more homogeneous and less intense. So these are some of the key distinguishing features. This is a patient who underwent a aortic graft replacement with a mechanical bileaflet valve. You can see that there's some pseudoaneurysm of the valve on CT. And again, with PET, you can see those areas that are pseudoaneurysm have associated heterogeneous and focal intense FTG uptake. What's also interesting that you can see here that there's this area, discrete thickening posterior, or I should say anterior to the graft, that again has associated FTG uptake. So this patient actually ended up having infection of the graft and was taken for repeat surgery. Again, same thing here. You can see that there's this on these CTA images, because there's contrast, you can see that there's a lesion there with associated FTG uptake. So again, showing you the helpfulness of having PET-CT fusion. Again, another example where you have this bioprosthetic aortic valve with heterogeneous FTG uptake. Again, strongly very suggestive of infection. This is a case of a TAVR endocarditis, which at the tip of the struts you can see that there's focal intense FTG uptake here. So on top of how does FTG PET help with diagnosis of infective endocarditis on top of the modified Duke criteria? You can see that with the sensitivity is improved, right, and the specificity is somewhat the same, or it's not statistically significant, but the value of PET-CT in endocarditis is improving sensitivity, so ruling out infection. So what are some of the limitations of PET-CT? It's not a perfectly specific test, so there's some false positives that can happen. Like I said, with inflammation, this low grade that can sometimes be mistaken for infection. Surgeons, when they implant a new graft, they use this thing called bioglue. That bioglue also can take up FTG, so that can sometimes be mistaken for infection. Thrombosis may not be infected thrombosis versus thrombosis. You can't really tell from just PET. And then when do you image? Because early after surgery, in the first 3 months, there's a lot of inflammation with post-op healing and that kind of thing. So if you image those patients in the first 3 months and you see FTG uptake, it might be just because of inflammation and early post-op. So it might be kind of difficult to distinguish infection versus inflammation, typically in the first 3 months after surgery. These are some examples of this. Again, if you can appreciate here, this is a patient who underwent graft replacement. This white thing here, this is bioglue. And you can see that this bioglue is taking up FTG in the PET FTG images. And again, see that it's more homogeneous and it's very low grade, so the SUV values usually are low in those patients. Again, a slide illustrating the importance of adequate suppression with a good diet. See, without versus with suppression, you really can't visualize the valves if you don't suppress these patients. Again, post-op infection versus inflammation. This is a patient who underwent surgery and in the early post-op period had PET-CT. This is an example of inflammation. See, it's low grade, it's homogeneous more or less, versus this patient with very intense FTG focal uptake that's heterogeneous, so more suggestive of infection. Again, similar slides to illustrate the concept of how do you distinguish heterogeneous inflammation versus homogeneous inflammation versus heterogeneous infection. PET-CT, like I said, is not the last test, so we have used that to follow up patients who have been treated to see if they have been responding to treatment. This is a patient with early infective endocarditis of the aortic valve before and after antibiotics. So see, after antibiotics, really has cleared up and you don't see any infection. Again, very strongly suggestive of infection in this patient. Attenuation correction itself can cause some artifacts. This is a patient with a pacemaker. See this very bright metallic pacemaker that can cause FTG uptake that can be mistaken for infection. So there are some algorithms on the scanner and with post-processing that we can kind of mitigate some of the effects of this metallic artifact. Again, endocarditis can diagnose local complications with embolization. This is, for example, you can see FTG uptake in the lungs. This is pneumonia with embolization. Again, on the CT of this lumbar spine, you can see there's discitis with associated FTG uptake. This is a patient who had back pain and actually ended up having discitis from distal embolization. Now, the accuracy of PET-CT for endocarditis is much better for prosthetic valve versus native valve. As Dr. Little was saying, to grow valve, you have to have a rough surface, right? If you have a very smooth surface, native valves might not be easy to visualize vegetations especially with CT. So the sensitivity in fact, of native valve endocarditis is really very low, 30%. And look how much better it gets with prosthetic endocarditis. Those valves, metallic valves, acts more of a nidus for fibrin and deposition of vegetation, so that is much better visualized on PET-CT versus native valves. The pooled sensitivity for PET, again, for prosthetic valve is, for infective endocarditis is 81% for prosthetic valves, and specificity is really also very high. Whereas the utility of PET-CT is really in those patients with probable endocarditis based on the Duke modified Duke criteria. You can see that there's a big chunk of patients that are unclear, so possible endocarditis. When you do FTG PET on top, that ratio is much lower. So you can be more certain, especially when you have possible endocarditis. There's some novel tracers that are being tested with PET. This is this fluorine 18 maltohexosose PET. You can see that has some improved specificity in PET as compared to PET FTG. Pacemaker infections can be seen, whether it's off the pocket or the pacemaker leads. And again, just know that early on after pacemaker implantation, patients can have FTG uptake in that area, but that is probably from the post-op healing and inflammation. And then, again, slide showing you that the sensitivity and specificity of PET for endocarditis is really very good. We're running out of time. So the last few slides are on LVAD. As you know, LVAD has multiple components. This is the older generation LVAD, where you have the pump, inflow cannula, and the outflow cannula. You have the drive line, subcutaneous, and then the across the skin. Now we know that the HeartMate 3 now you don't have an inflow cannula; it's just attached to the LV apex. But you can get infection at any of those 4 sites. Okay, and we can visualize that with FTG very well. So this is a patient where you see that there's FTG uptake here at the site of anastomosis of the outflow cannula with the ascending aorta. Again, better seen on this image here. This is a patient with infected FTG uptake of the drive line. Okay, and then you can also have infection of the pump itself, although it might be hard sometimes with metallic artifact. And clearly patients with LVAD who have infection do much worse over time. So it's very important to diagnose those patients early on. And the more number of components that are infected, obviously the worse survival. And the higher peak SUV, which kind of tells you the severity of infection, also the worse the survival. So the guidelines, I'll just leave them here for you to read, but cardiac CTA is recommended in patients. It's a class 1B. Again, usually it's a second step after echo, and it's better for prosthetic versus native valve. And if you're unsure of the diagnosis with CT and PET, FTG tag WPC scan can also be helpful to help with the diagnosis. All right, and that's all I have for you. All Dr. Mallah has for you. Yes, sir.
Just one comment. One of your first slides, you had a nice comparison of TE versus CT for all kinds of sensitivity, specificity. Particularly, we talked about complication identification.
Right.
There was another thing, maybe after this, you had actually, you showed one where the CT demonstrated more perforations than the TE did by a couple or so. But in that comparison, the suggestion there is that the gold standard is actually CT. I would say the other interpretation of that is that CT overcalled the perforation, which I think is more likely, because in our experience, if we've had several times where CT has said it's perivalvular leak or a perforation or something, and then you apply a flow test, and there is no flow.
Right.
So I would say all the other complications and identification I completely buy, but I would say CT is not better at perforation.
Perforation, I agree, especially with the, sometimes spatial resolution cannot be as visible, and anatomy doesn't always translate to hemodynamics, so flow is really the goal, should be, I agree with you completely, that echo should be the way.
All right.
All right, thank you.
Thank you all.